So for the next hour, we're going to be discussing investment and financing for NCDs and really trying to be solution-facing and forward-facing as we think about paths for sustainability. I am honored to have such an esteemed panel. I'm going to start with quick introductions, and then I'm going to do sort of a quick framing and then really sort of get into the heart of the matter. And we'll leave maybe about 15, 20 minutes towards the end of this session for Q&A. So I want to first introduce Jennifer Bay, who's the Executive Director of Global Innovation for the American College of Cardiology. Andrea Feigl, second, I guess maybe I didn't line up everybody in order. So if you could just sort of wave when I call your name. Founder and CEO of the Health Finance Institute. Nafisa Jawani, who just joined literally in the nick of time. The Managing Director of Health Initiatives for U.S. International Development Finance Corporation. Vandana Shah, who's Vice President of Health System Strengthening for the Global Health Advocacy Incubator. John Simon, Founding and Managing Partner, Total Impact Capital, and Elizabeth Wangia, Director of Health Financing, Ministry of Health in Kenya. So obviously, we all know, because we're practitioners in this space, the huge challenge that we're facing with NCDs, and we're really facing a triple whammy in that the burden of NCDs is significant. It's growing fast and furiously at a time when aid's being cut and debt burdens are rising really everywhere, but particularly in low and middle income countries where we're going to focus this conversation. Excuse me. So we're going to take on sort of this challenging question of what do we do and how can we better work together? Because again, not only are we facing sort of a triple whammy, but both, all three of those pieces, right, are getting worse. And I think while we're a group of well-intentioned actors in this equation, we do need to sort of reset and figure out what we're going to do. So really what we're going to try and focus in the next hour is how do we pay for all of this? And so I want to first start with Andrea and ask her to help us put some of these financing challenges for NCDs into perspective and I guess try and articulate or distill for our audience so we can really sort of jump in, like what are the pain points over the next 5 to 10 years?
Thank you so much for having me and allowing me to space on this panel and talking about a topic that I have been deeply caring about for over 15 years now. So as you mentioned, we are facing a slow-moving tsunami, to put it in the words of Dr. Tedros. We are basically looking at an economic scenario where really globally, we've done these studies, about 5% of GDP growth is being impacted because we don't invest in access, care, and treatment and in interventions that we know. So 70% of deaths globally are caused by chronic conditions. In low and middle income country, more than 60% of the burden of disease is caused by non-communicable diseases. And in the US, about 9%, we experience like a 9% effective tax burden because of underinvention in access, prevention, and treatment. We've also modeled with some of our partners looking at what would it mean to have a basic universal healthcare package that is inclusive of a diagnosis of treatment of a host of chronic conditions. And even in the best case scenario, which we're certainly not in right now, by 2040, less than 50% of low-income countries would actually reach basic UHC targets. So the picture is a very stark one, and it should really move us to action. And so some of the things that we can do and that are doable is really investment in digital diagnosis and prevention. There were studies, one actually in Kenya, that looked at that 50% of the cost can be saved by implementing digital solutions at scale. We can also look into really investing in something that is called the best buys, where $1 spent yields $7 in return to economies. And we really have to look at both the effectiveness and growing the fiscal space. And then I want to be a bit provocative because I'm starting and I have a mic. And so I was here 2019. We just had started HFI, and we were working on a multi-partner trust fund business plan for non-communicable diseases. And some of us, and some partners in the DC community, faced us with quite a lot of opposition because they said we don't want to have another vertical a response to NCDs. And 6 years later, almost, we have a multi-partner trust fund, but it hasn't really been capitalized beyond $3 million out of the 200 that they're trying to raise, which is really a concerning picture given the numbers I just cited. So we have another 2025 UN high-level meeting next year, and we in the financing community are gearing up. What are the messages? But it is the 4th UN high-level meeting on NCDs, and so where's the money? And there was a conversation, and it was Tom Frieden in the room, the head of Resolve to Save Lives, is Michael Anderson, CEO of MedAccess. And they were saying, we should have a global pool procurement system where we have something like the poly pill that can address for 6 cents per poly pill, really 5 of the biggest conditions such as heart disease and diabetes, and it could be really effective. And then the response by some other partners, and there weren't any countries in the room, were like, well, we don't want to sidestep the country's wishes and procurement processes. And since we have Kenya on the panel, and since I'm actually a proponent that we should do both international and national responses to scale up financing, I'm very curious to have a conversation and to hear what you as a strong leader, and Kenya has been actually at the forefront of leading the NCD financing discussions with the WHO, have to say, if it's a bit no, if it actually will be a welcome solution as well. Thank you.
Dr. Elizabeth, do you want to respond to Andrea's call to action or question?
Sorry to put you on the spot.
I'm not sure whether and forgive me if I've not really maybe gotten the concern exactly, but as a country, as I indicated, we have our, I would say our roadmap or our vision. And as we move forward, we really want each and every partner, including the WHO, to align to our goals, because we are the ones with the burden. We know where we are right now. Right now, NCD is still underfinanced. We actually have a 91% financing gap, so to speak. And therefore, whichever move that we can make to, narrow that gap, we may not get to 100% financing right now. But whatever discussions that would, bring us together and, to narrow that gap, whether it's in terms of improving the financing, whether it's a matter of improving the intervention so that we can actually get more health out of whatever money that we have, then that is welcome. And of course, some approaches still, as mentioned before, is just looking at integration, primary healthcare interventions. They have the potential of freeing up resources that we already have, and therefore having a bigger impact when it comes to the management of NCDs. I'm not sure whether that touches on it a bit, or maybe you can rephrase.
First of all, sorry for putting you on the spot. Second of all, sorry for perhaps changing the course of this panel. Be that as it may,
that's why I was standing up, Andrea, because I was waiting for it.
So thank you, Dr. Wangia. That was, I think in terms of what you said about anything that helps us lower that 91% gap would be helpful, I think is the answer. The bigger question, and maybe we can discuss it in discussion, was, if there was something like a pooled fund for certain drugs where Kenya could have access to it as well as other countries, would that be a hindrance to building the procurement processes in your own country, or would it be additive and welcomed? That sort of was the question in the room that nobody from a country perspective was able to answer last week.
Yeah, so actually amongst our key priorities, so to speak, in the last 2 years has been around strengthening commodity security. Our main focus right now is around local manufacturing, whether it will be, local as a country or even regional. We are soon setting up a regional, we'll have a regional, I would say, local manufacturing hub, starting with vaccines. But of course, over time, it will expand to more and more commodities. So yes, such an approach will really be helpful, because if you think about the cost drivers for health, topmost is actually commodities and human resource. So getting modalities of purchasing commodities in a strategic manner will definitely come a long way in even, helping reduce the cost of healthcare. We have looked at even discussions of pooled procurement methods, still having stakeholder engagement, because it's a new concept, different stakeholders involved. There are those who could feel aggrieved by such an approach. So these discussions are ongoing on how to just implement this pooled procurement method for key interventions. We may not do everything at the same time, but we may want to look at those commodities that are actually that are considered expensive, and therefore take advantage of that and probably leave the local manufacturing for the day-to-day commodities.
Thank you both. Nafisa, I want to bring you into the conversation. I know DFC is sort of aggressively moving into this space. And I guess as you hear, Andrea and Elizabeth talk about this as a potential solution forward, how does that align to the way you're thinking about the problem, and how are you mobilizing, both the financing and sort of power of the US government to help support?
Sure. Thank you for the question. So for those in the room that don't know, the DFC is the US government's development bank. And so we provide financing tools specifically for the private sector to increase opportunities in emerging markets. And that's really why we were formed 50 years ago as OPIC, and we've just transitioned to the DFC. I guess now it's been 5 years, so we're not so brand new anymore. So our focus areas have really been three separate areas. The first is on health system services and delivery, so anything that is brick and mortar. The second is around manufacturing and supply chain, because we also believe it's critically important to establish local manufacturing capacity. And the third is this intersection of health and technology. When we were designing our health strategy, I don't know how many people know this, but when we were first thinking about where is it that DFC could really be additive, as you think about just the number of tools that we have within the US government, our focus was really going to be on NCDs. And the reason is that most of the grant funding that you find in US government is focused on infectious disease. So this was an opportunity for us to really narrowly focus on something where there's no funding really at the US government level. Pandemic hit, we decided clearly we need to rethink. And I'm glad that we've pivoted so quickly, because there's a need for manufacturing and supply chain beyond vaccines. I think vaccines is critically important, but therapeutics is critically important as well. And we're thinking about NCDs in particular. How do we reimagine the way that health is being delivered in an emerging market should be something that we're thinking about. I used to be at the Centers for Disease Control and Prevention in the US, and so I actually worked with Dr. Frieden quite closely on policy and strategy. And I think that what I'm seeing is the opportunity for us to leapfrog in the health space, and DFC being a partner in helping innovators create those solutions that make sense in emerging markets. So I'll give you one example in terms of what we've financed recently in the NCD space, and then opportunities as well. So we recently financed a company called Africa Health Network. And Africa Health Network is a company that is providing dialysis care in East Africa. I'm sure that you're very familiar with AHN and the team there. And it's been really lovely to see that expansion, that growth. And if you go into a facility, the AHN has taken over. What you saw before was, sometimes a facility in a hospital that had mold, had really small space for dialysis care, not state-of-the-art equipment. And by providing financing to AHN, we're seeing much better health outcomes. And that's important for DFC because we're looking at financing projects that both meet development priorities and foreign policy priorities. The tools that we have at the agency include debt financing, equity, which I think has been quite nice to actually have because it wasn't a tool that we had before. We also have political risk insurance. And so as companies are thinking about coming into an emerging market and they're trying to hedge their risk, like being able to make sure that we've got political risk insurance for those companies as well. We have loans and loan guarantees. And so those are the products that we use to tackle some of these things. But NCDs continues to be a discussion item every single time we go into a country. We're talking to the Ministry of Health and they're saying, how are we going to deal with oncology here? We're not going to be able to have chemo treatment the way that we have in the Western world. And so what does that look like? And so diagnostics becomes critically important because if you catch something in stage 1 and stage 2, you're going to have a much better health outcome. And so what are the ways in which DFC is looking at this is really partnering with countries and with the private sector to create those solutions and then hopefully provide financing for private sector partners.
Great. Well, so speaking of countries or companies coming in and helping with this, John, I want to turn to you and get your thoughts on, how can private capital sort of help this vision that's being laid out and sort of help support that. And also because we have so many innovators in the room that, are interested and actually have solutions that are addressing NCDs. How do they think about and access private capital?
Yeah, thank you very much, Lisa. And it's great to be here with such an esteemed panel. When I hear about, Kenya having a 91% funding gap for NCDs, I mean, it's apparent there's no way that gets filled through the traditional channels. You're going to have to take a different approach. And, from our perspective in the impact investing world, so Total Impact Capital is an impact first investing firm. We try and mobilize capital into opportunities that maximize impact with sustainable returns. And health is one area that we do a lot of. We recently were part of the final close for something called the Transform Health Fund, which was our friends at DFC were one of the early participants, which is doing what I think part of the answer, which is providing capital to fund the scale up of innovations that can make a real difference. I mean, I think one thing that Andrea said is we have to look at both sides of the equation, both where you're going to get the additional resources, but also how you're going to reduce the costs. And at the way that we treat cardiac disease, stroke, neurological disorders, all those things here is not a way that can be exported into the developing world and be funded. And so we need to, as you said, we need to look for innovations on how to do that. And a lot of those innovations will come, most of those innovations will come from the private sector. And so how do we create funding mechanisms that can find those innovations and bring them to scale with an eye towards serving not just the top of the pyramid, but the underserved? And that's obviously what we're trying to do with Transform Health in Africa. We have a new funding vehicle called Live Health, Latin Impact Ventures for Health for Latin America. And the goal of these vehicles is to basically drive the financing to find those entrepreneurs who are really the ones who are going to come up with the solutions that make a difference. And if you just take a few examples, there's a company that we're looking at that uses AI. And by the way, we do happen to sit at an important turning point in technology where we now have technologies that can potentially create not just the leapfrogging 1 or 2, but several generations effect. So uses AI to read EKGs, and there are not enough people to read EKGs in Africa or Latin America. But with AI, not only do they read them and give you an immediate result, but they also identify risk factors for cardiac and stroke and allow you to do the preventive type of measures that will reduce the cost for those diseases earlier than would otherwise happen. We're also working with Zipline on the commodity supply chain that can make sure that you can track a commodity from the moment it enters the country to the moment it hits the clinic, the whole way, knowing exactly where it is. So nothing falls off the back of the bus. Nothing stays in a warehouse until it expires, and you're able to have tremendous savings in that regard. So I think the first thing we have to look for is how do we get the financing mechanism in place to support the innovators who are out there? Because as you say, there are plenty of innovators, what one of them you'll talk to will say is they need finance, and that's a critical component. I think the second thing is to think about different models for payments. So again, the traditional models that we have here in this country just won't cut it when you're trying to create efficiencies and opportunities. So you have to look for things like, equipment as a service instead of as a commodity, and being able to pay for the uptime of the equipment instead of have to lay out a large cash installment to buy the equipment up front. Case management as a service, so that you again are able to incentivize a private provider to treat people, to manage their chronic diseases effectively and reduce the cost that way. And then the final point I would say is, the private sector in the employment world, there's a lot of resource there. And again, if NCDs aren't treated, that's going to be greater absenteeism. That's going to be greater insurance costs. That's going to be greater costs. The private sector, the tax, I think, as Andrea has pointed out, it's a massive tax that's going to be borne by the employers, and they can get out of that if they invest in providing the type of efficient, effective early care that's going to make a difference.
Great, thanks. So staying on this theme of private capital, Jen, I want to turn to you and ask you a little bit about sort of American College of Cardiology's venture fund and how you're thinking about this intersection of deploying capital, but also, like, from your vantage point, thinking about the workforce and sort of the innovative way you're basically using a professional association to maybe tackle both.
Thank you, Lisa, and thank you to my colleagues here. I'm so excited for the chance to learn from all of you. The first thing I'll say is that despite our name, the American College of Cardiology, we are in fact a global organization. So 1/3 of our membership sits outside of the US. We have particularly strong ties in Kenya, for example, through the Kenyan Cardiac Society. And when we think about innovation, we tend to think about it from a healthcare workforce, but also a healthcare access lens. ACC's mission is to transform cardiovascular care and improve heart health for all. And we tend to think about that from a lens of how clinical knowledge, science, and innovation come together to drive that sort of change that we wish to see in the world. When we started our innovation program in 2016, 2017, and started investing shortly thereafter, we were thinking about what impact could we have as a global medical professional society to promote the development of technologies that are patient and clinician focused and oriented, because all too often, a lot of these technologies are built in a vacuum where a clinical voice and a patient voice is absent from the development and deployment of that technology. So when we started working with tech companies to help them think about the development of their technologies in consideration of clinical workflow, the investment piece ended up being a follow-on from that pretty swiftly. And we tend to think about that. I want to call up some points that were raised already by some of my other panelists as illustrative examples. Screening technologies are a great example of that. We know that so much of the world is walking around with undiagnosed disease. Cardiovascular disease is unfortunately the leading killer of human beings on planet Earth once they reach adulthood. And so how do we do a better job of using technology to reach people and communities to detect disease early on, or detect risk factors for disease early on when we can do something about it? That goes back to some of the points that were made by some of my other colleagues already on the panel about then saving money within the system, because it's a lot easier to prevent disease, a lot more cost effective to prevent disease than to manage lifelong illness, both from an economic productivity standpoint and from a cost to the healthcare system standpoint. The only other piece that I will add here before turning it back to the group is a piece about thinking, and it was something that was brought up early on in the first session by Krishna and others. We are a cardiovascular organization, but I don't want folks to think that Jen is only interested in cardiovascular technology. I am super interested in technology that allows care to get to people in the communities where they live and work and connect through the appropriate channels back to the next appropriate provider. Because the way that we are going to build systems that work is by collaborating across disease states to build a functioning system, and not to have cardiology systems running in parallel with diabetes systems running in parallel with oncology systems. And so I wanted to offer that back to the group and introduce the concept of integration in this space too, because I think that folks that are funding this should also be thinking from that lens.
Great. So I want to just cue the audience that in about maybe 10 minutes, we're going to be coming to you for questions. So please be thinking about that. Vandana, I want to bring you in. So you've had a lot of experience helping to support governments shape their policy and financing as they think about and grapple with this problem. So what sort of bright spots or models do you think might be illustrative or relevant to this conversation, and sort of maybe sort of something that we can look to?
Thank you, Lisa. So I guess I bring a really different perspective because the Global Health Advocacy Incubator and our parent organization Campaign for Tobacco-Free Kids, our entire focus is on domestic resource mobilization, both for communicable and non-communicable disease. So I'm going to share kind of, two kind of major ways in which we've sort of had, success around NCD financing. One, which I think, more and more it's like critically important, especially in sort of a post-COVID world where again, sort of the focus has shifted on communicable diseases, really looking at health taxes as a driver. So we're doing a lot of work on increasing tobacco taxes as well as SSB taxes across Asia, Africa, Latin America. And that has been a major source for funding NCD programs. I'm going to quickly share two examples, which I was personally involved in an organization led. And I want to say that much of our work on NCD financing is funded and supported by Bloomberg Philanthropies, which, as you know, Mayor Bloomberg is the NCD ambassador for WHO. And a lot of our work on cardiovascular health financing is supported by Resolve to Save Lives. So, so we're sort of working across and we work closely with WHO. So I would say that Bangladesh, which is a really resource-strapped country, they did not have a single dollar sort of allocated for tobacco control. And it was completely sort of donor funded, through Bloomberg Philanthropies. And we did not really see any ability to actually embed a line item for tobacco control and NCDs. So we worked with the government to impose a 1% surcharge for all tobacco products. And this was way back in 2013. This yielded like several $100 million. But over time, we've now managed to create a sustainable line item. This wasn't a earmarked tax, but we managed to create a sustainable line item where now the government is investing $5 to $7 million every year for tobacco control. So that's been a huge sustainable way. So increasingly, we're getting governments to look at health taxes because it is a win-win. You're reducing consumption of SSBs as well as of tobacco, and you're creating a sustainable domestic resource for, for funding NCDs. Similarly, Philippines is probably one of our best examples where, again, a tobacco tax was used for funding UHC and as well as other NCDs, So that's something increasingly we kind of really work with ministries of finance, because this is not a Ministry of Health strategy, to really sort of look at a whole of government approach with both executive leadership in countries to look at, as they're trying to address NCDs, to look at taxes. The other great example I would say is from my home country of India is around hypertension, cardiovascular health, and investment. So we had partnered with Resolve to Save Lives in WHO to launch like the largest hypertension control program in the world called IHCI, or the Indian Hypertension Control Initiative, which was initially kind of primarily funded by Resolve and other global funders. And as the program, coming from donor funding was, sunsetting, a big role for my organization was making sure it's fully integrated and scaled up, because the pilot was only in up to 10 states, to taking it across India. So the entire project, and it actually received the WHO award at UNGA 2 years ago as sort of a global best practice, was fully integrated and scaled up to all 29 states over the last 2 years into the government's NCD program. So I do want to say that, it's still a struggle and a stretch. And now we're increasingly beginning actually work on NCD financing in Africa based on some of the successes and models, especially around taxes, as well as sort of really doing a lot of sort of investment case analysis. We also support a huge sort of civil society coalition in all of the countries to lead sort of an advocacy, making the investment case. case because most countries are investing less than 1 to 2%, even on the 5 major NCDs. When you're looking at cardiovascular health, respiratory, diabetes, mental health is probably the least funded of all diseases in countries. So I would say that, we're really sort of emphasizing, sort of the cost benefit ratios, doing very, investment case analysis, but also really putting a public face to it, building together NCD financing coalitions. We are just here about to launch in Nigeria around cardiovascular health. So I think there's a great opportunity. In fact, we very much like to, partner with sort of the kind of funders you represent to bring in as to what is the sustainability plan. So if you're providing financing in a country, our model, and, we also talk to the World Bank continuously, others is, where is the continuity when the multilateral or development bank pulls out? And so our role is really about sort of making sure that the country is thinking long term and sort of using sort of that initial seed capital from a multilateral bank or a global funder as a pathway to sustainable domestic financing.
So we have such an amazing set of approaches and expertise and capabilities here. So I mentioned in the first sentence of the opening that we wanted this to be solution facing. So to the panel, I guess I'd love for all of you to react. Like, how can we start to weave and unify around a common solution? What does that solution look like? And I guess we can sort of focus on Kenya as an example, given that 91% gap. How do we start weaving these threads together? And what's the beginnings of a solution that we can move forward with?
I would want to sort of question a little bit the premise of the question. I think there are lots of solutions to move forward. I don't want to be pessimistic. I think we're actually very optimistic because there is a tremendous opportunity, a giant market in NCDs that's unmet. And so from a business perspective, there's no doubt that there's a great opportunity. But I do think I think of Bill Easterly's sort of dichotomy between planners and seekers. I do think resolving the challenges in non-communicable diseases is a job for seekers versus planners. There will be lots of different ways to employ AI, for instance, to identify risk factors and then address risk factors. Lots of new care models. I mean, there are hundreds of them that are now proliferating throughout Africa and Latin America, and we'll have to see which ones work and which ones don't. And some of them will work in one ways and not in others. We have to combine. But I guess my view is I would focus more on the ways that you can create sort of the 1,000 flowers bloom type dynamic, as opposed to trying to find this is the way to do procurement, this is the way to do care delivery, this is the way to do claims processing, or whatever else the other basic systems of health delivery are.
I think I would 100% agree with John in that I don't know that there's a silver bullet. This is a multi-pronged approach in terms of how do you address these issues. And I think of DFC's role when we're working with the private sector, especially when we're thinking about NCDs in particular, is that we're giving an opportunity for entrepreneurs to scale their solution. And a lot of the time, what we hear from those entrepreneurs who are on the ground saying, we want to be able to complement what the public health sector can't do or can't do yet. And so innovation usually is exciting, but not something that's going to be scaled right away. And so I think being able to provide financing solutions to those entrepreneurs that are creating solutions to get to, areas that you otherwise wouldn't be able to get to in terms of providing care or creating different ways in order to provide solutions too. So I think of Kasha as another example of, again, in Kenya, where they provide, it's an e-commerce platform, but they are able to provide medicine, RTDs, and pregnancy tests and sanitary pads, but also sugar and rice. And so that, any person who is, maybe further away will have a Kasha bag, but no one will know what's inside that bag. And so there's anonymity in that. And so that to me is like really incredibly creative, but not something necessarily the public health sector could do. There's an opportunity to take the strain from the public sector by being able to have these private sector solutions. And so I think that's going to be a little bit of, what is there in terms of an opportunity? And then from a financing standpoint for us, like how is it that we can help these entrepreneurs scale? And scaling is really daunting, especially when you're used to getting grant funding. To go from grant funding to a loan is no small feat. And so being able to help those entrepreneurs along the way, I think is our job for sure.
I just wanted to piggyback on some of the great points mentioned earlier. And one of the things that I wrote down as colleagues were introducing themselves and their points of view was the word efficiency. Efficiency can mean cost cutting, and that's not the way I want to apply that. But what I mean is each of us is interrogating this problem of health system strengthening from a slightly different lens. Everything from country-based financing for specific solutions to, venture funding for technologies that might support those solutions. And I think what aligns us in common cause is the creation of sustainable and scalable solutions that span multiple conditions. And so I think I want to turn to Dr. Elizabeth and see how that plays out in Kenya.
Yes. Just to chime in to the discussion, speaking from a government perspective and not a financial perspective, I think as government, we have the sole responsibility of creating a conducive policy environment for, say, the private sector, investments and innovation. Because if there are quite a number of maybe restrictions when it comes to investments, then it will deter the private sector from even investing or from coming up with solutions. So just looking at what is this policy environment we can put in place that will encourage, innovation. Then just looking at probably, and this is something we discussed as we were developing the benefit package, how can we incentivize even the people? Like for instance, these days we have all these wearable devices and the like. How can someone who has constantly done 10,000 steps be waived even when it comes to their health insurance? So such approaches, they were on the table, and I think it's something that can incentivize. Right now, people are contributing 2.75% of their gross salary towards the social health insurance. It's a big dip. There's a lot of outcry around it, even if you are to search right now around social health insurance. But then such incentives can also help, and they are inexpensive. And of course, they'll have an impact. I think the other point, apart from just creating a conducive environment for the private sector, is to be open to actually partner. As it is right now, I would like to say, as Kenya, in the last 8 years ago, was it around 9 years ago, we had what we call the managed equipment services. And this actually increased access to especially diagnostics for NCDs and also for dialysis. The access to dialysis services is quite good in Kenya. So there was this pool procurement of equipment at county level. And, there was this good payment plan with, payment plan for the equipment. And this procurement included availing the equipment, servicing the equipment, training of the providers. But then the repayment was in a flexible period over the last 7 years. Right now, we are still we have engaged in fresh discussions around that, especially this equipment that are capital intense. Seeing how can we have arrangements like placement, have some framework agreements, fee for service agreements with the private sector, and the private sector is quite open to that. The only challenge that we have is in terms of data, because without data, at the end of the day, the private entity wants to know, will I really make my money? Yeah, so, and without data, like even in terms of, for instance, lab utilization or even radiology utilization, it becomes a challenge. But of course, it's work in progress. Some of the solutions that we are having.
So I just wanted to share 2 quick learnings from working primarily on sustainable government financing. So one, I always share that increasing budgets in low and middle income countries is 30% of the work. Getting them to actually utilize the money is 70% of the task. Because, after we allocate this money and I go if we actually step away, most of the money is unutilized because of the sheer bureaucracy and inefficiency of government. So one of the learnings we found for just NCD delivery at the primary healthcare centers, there are two streams of funding that can potentially fund it. One is obviously that every government has an NCD stream to buy the hypertension medicine or the insulin. And then you have a large primary healthcare budget. Both of these actually never coordinate to fund this. So for, when we were working in like the state of Punjab in India, we find that, the right hand and the left hand never talk. And there are gaps in, the medication at the primary healthcare level, but they're not even coordinating. So a lot of this was tapping into these resources to deliver the services. The second sort of learning working with sort of the public health system is there's a lot of inefficiency, since, the theme is efficiency, because to get like your refill for a basic hypertension, if you have controlled hypertension, you're still going to a tertiary care center where you're imposing a lot of cost. Because we found that the primary healthcare center where the person goes within the next hour does not cover amlodipine, which is a very basic, very, very cheap hypertension drug. So we actually had to spend a year in advocacy to get it on the essential drug list of the primary healthcare center. So I want to say there's a lot of when you look at sustainable financing, actually getting the money in the books is just one part of it. Then creating the efficiencies for them to use that money, deliver it in the most cost efficient last mile, served level is another whole sort of level of workforce financing planning. So, so I think there's a lot of lessons which now as we kind of distill, we apply as we go into, other countries.
Great, thank you. Nafisa, Andrea, before we open it up to the audience, do you want to react to anything that either Dr. Elizabeth just said or any of the panelists have said?
I want to talk to Dr. Elizabeth afterwards because we have so many projects in Kenya, so I'm excited to have a conversation. But I mean, nothing more to say other than I think that this, when you're asking about what is the solution, I think part of it's also bringing stakeholders together to say, how do we solve some of these issues in a way that's meaningful? And then how do we share what's being, what works in a certain context, may not exactly work in another context, but there's a world in which we can find a way to at least take best practice. I think, Andrea, you've been talking about this quite a bit as well. So I'm stealing from our conversation last week. But like, how do we help provide solutions to health ministers that are really struggling with the increase in NCDs in an area where if you are a low-income country and you're transitioning to a low middle income country, you are really now struggling with infectious disease and non-communicable diseases. And so I think that the creativity and the opportunity for the private sector and public sector to work together is quite large. And I think these types of discussions, I think, help us to figure out opportunities to collaborate for sure.
Just to build on everything that was said and quite brilliantly. So the HFI has done a study where we looked at over 10 years of public-private blended finance, so basically public-private or different shades of capital from the public sector being blended, and what worked in the past to understand what could work in the future, particularly vis-a-vis NCDs. And what we found was when it came to commodities and procurement, several blended finance mechanisms actually worked, less so in sort of service delivery. And when it came to policy instrument and outcomes-based payments, these types of structures work more so in a middle or higher income setting. So understanding where we can deploy private capital versus where we can't so easily, or where it hasn't been done so easily, I think is really important. So I just want to add to as like we absolutely believe in building the investment cases and doing economic analyses. And I love the Vandana, what you mentioned. I love all the work that you're doing. It's really amazing. But then we at the HFI also would like to help build the technical capacity to deploy different resources in a different manner. So we don't just have one or two ways of structuring financial responses to healthcare costs, but we actually have a whole toolbox.
Great, thank you. Oh, John.
Yeah, there is, so I opened this sort of round of questions by saying there are no global solutions, but there is at least maybe one thought I have about global approaches that might be worth thinking. I mean, a lot of the small, the early stage companies we work with, and one of our partners, the Pharmaxis Foundation out of the Netherlands, has this saying, start private, grow public. Ultimately, to get to scale, they have to have public sector relationships. And a lot of the private sector, small scale, early stage companies we were working with have a very tough time interfacing, not just with governments in their countries, but also with this whole world that we live in here in Washington, the donor world. And so and part of that is because you have all these procurement regulations that make it very tough to distinguish, between someone who's offering a true innovation and someone who's, offering to do it the same old way, and to sort of identify where you're getting real value for money. And so one thing I do think a way to cut through that is to focus a bit more on paying for results as opposed to procurers. Now, I take your point, Andrea, it's not easy to do in some of the toughest situations. But I do think that is one way to give innovators a chance to compete against sort of the entrenched providers by saying, all right, if you really can provide this result at a much lower cost, we're willing to pay for that. And one example that we just announced last week at the UN General Assembly was a partnership between the government of Nigeria, the Ministry of Health in Nigeria, and Zipline to basically create the largest automated logistical delivery system based on a pay for results framework.
Great. So audience questions.
Hi, I'm Rubayat from Endless Foundation. So oftentimes, like we've talked about private sector engagement a lot, but oftentimes governments also have a blind spot with respect to what's happening in the private sector. So for example, I was an entrepreneur in Bangladesh working with a large network of pharmacies. And we would see that of the 10,000 or so pharmacies we were working with, they were actually seeing on average 8 NCD patients a day. They were doing things like blood tests. They were like the glucose tests. They were doing things like blood pressure tests. And sometimes they would even actually provide the blood pressure tests for free as a way of kind of contributing to the community and kind of contributing to their well-being. Like right now, we're funding from the foundation that I'm at, we're funding an organization called Penda Health in Kenya, where they have a population of about 1.7 million that they serve, and of them about 30%, so about 500,000 people are potentially NCD patients. And they are seeing the value of creating kind of customized pathways for NCD patients, because that ends up contributing back to their bottom line. Now, like to John's point, I think if there was a mechanism for some sort of a capitation plus performance-based incentives model that put these kinds of different social enterprises, nonprofits, to be able to contribute to NCD results, and also compete with each other in a marketplace, right? Like be able to say, I am able to generate this amount of result for less than the neighboring organization. Like what are the barriers to setting up mechanisms like that, that the governments are doing, or are you already thinking about it? Thank you.
Who wants to take that question?
I mean, I'm curious as to how the government at that. For DFC, we think DIBs are really a great opportunity to work with the private sector, and we have financed DIBs before. So a development impact bond, and we've done this with in Cameroon with cataract surgery, and so it's something that these are complex financial structures that we're putting together, so that's a little bit of a challenge. But at least at DFC, there's a lot of interest in doing this for the exact reasons that John mentioned, is that there's an opportunity then I think for the private sector to really be able to show outcomes, and hopefully then engage with the public sector in saying, look, we've been able to do X, can we scale this and work much more closely with the public sector to do it together? And so for us, at least, I think that they're just complex structures. It's not that we can't do it. And so I'd be happy to look at them if you have something for us to explore. But I'm curious to hear for the government of Kenya how they would think of it.
Yeah, so I think that what you have said is absolutely correct. Just today, I met my fellow Kenyan, and she told me a lot of work that they're doing. And as government, I don't think we are really aware of a lot of that work that they are doing. Though in Kenya, we have a clear what we call partnership framework between the various actors, the state and non-state actors, including even the civil society, the private sector. It's very structured. We have even, like a clear governance structure on how we meet on a quarterly basis and exchange ideas. But then I don't think we really go and deep dive or have an opportunity where all these, say, innovators, all these private entities come together and actually tell us what they are doing. And there's no platform for them to report to us. So you'd find someone is somewhere doing something very good, but we as government really don't have don't have an idea. And I don't think it's necessarily because we don't want to know, but I think we have not just strengthened that, interaction where we can actually share what each and everyone is doing. So I think to me, that's, I just sat down and I thought about it. I think it's something that we may want, because we have, for instance, we have a whole private sector structure. We have the Kenya Association of Private Hospitals, if it's hospitals. We have the Kenya, it's called KEPSA, Kenya, where all now the private entities, leave alone the ones even related to health, come together. And with these bodies, we can actually reach each and everyone. So just trying to have avenues, maybe even like a conference once in a year where people just come together and share what they are doing, I think would really be helpful even to us to just embrace and appreciate what the private sector is doing.
Thank you. This is Sam Guer from Afya Research, Nairobi. I think one of the beautiful things I've had out of this conversation is the word integration and the opportunity to leverage existing primary healthcare resources to piggyback NCD interventions. It will be a tragedy if in all these efforts, we then start developing siloed interventions, focusing on the various bits of NCDs that we're interested in. So that's really nice. What I will ask the funders and both in the platform and in the audience is whether you'll be interested in funding energy solutions for the health sector, because that's a component that is really little funded. Poor energy means you can't store vaccines for NCDs like HPV. It means you can't store insulin, and yet it doesn't beget the revenue feedback or the impact feedback that directly speaks to what you've put in. How do you address that?
You want to go first, John?
Just to understand the question that you're looking to address, because I think it's something we've been talking about before. How do you come up with business models, reimbursement models that incentivize the type of innovations that we're talking about?
Yes, that support access to energy.
Oh, and
yes,
that's what I thought.
Electricity. So in all this, electricity is an enabler. We are speaking about technology, but without electricity, that's a problem.
Well, here I'll defer to the FISA, because energy is one of the big things.
It is. Energy and infrastructure is why OPIC was really created, I feel like, right? To increase investments in energy and infrastructure. We just started doing health investments in the last 5 years. And so arguably, I mean, we were just in New York at the UN General Assembly, and a lot of the discussion was really about, I mean, if we think about it from a really broad standpoint, these are like, at the bare minimum, you could think of it as social determinants of health, but what are all the things that are required, whether it's energy, whether it's access to clean water, whether it's oxygen, what are all of the things that are needed to create an enabling environment to deliver healthcare? And so at least at DFC, infrastructure and energy for sure are priorities for us. And we invest in energy and infrastructure all the time. It's like what we know best. It's our bread and butter. And in the last few years, we've increased our portfolio to include critical minerals. We also invest in agribusiness in addition to health. We have an entire workforce focused on climate and now really thinking about this intersection of climate and health. And then we also have focus areas. I think I've said agribusiness, I've said health, I've said infrastructure, I've said energy. John, am I missing something? Catalytic capital. But I mean, like from a sector standpoint, those are the sectors that we really focus on. And we think that they're as important as why you're saying, like, if you don't have energy, how are you going to be able to create a supply chain that's going to support vaccine manufacturing or therapeutics?
So I'm going to just chime in here because I think you raise a really important point, because the needs to deliver NCDs at the primary healthcare level are so basic sometimes. So the super quick story I'll share is we were just started working on hypertension delivery at the primary healthcare in Punjab, and COVID struck. And so we then moved to a telemedicine model for all of these primary healthcare centers. And we were, the state of Punjab had a fairly, center which wasn't function, the central center. So they were willing to invest, in the staffing to build up the center so that people could come in and call for whatever NCDs or hypertension. And we're not a funder. I'm an advocacy organization that provides access to domestic or global funding. So they made a request to us that none of these primary healthcare centers have internet access. So they have a computer, but they have no internet. So they requested us if we could fund them with those internet dongles to be able to connect to the internet. So we actually, and those were like, I think $100 or something. So we actually pulled in some emergency funding. We didn't even have time to provide them access to dial in so that they could actually have someone come into that center who probably didn't even have a smartphone, and then to come into the center, dial in to the telemedicine center. So sometimes, your question is the needs are so basic in order to kind of access at the bare minimum, you're talking about refrigerators are not there at most of these places, leave alone electricity, So I think that all of those challenges you have to kind of meet, because you're talking about things which are much more upstream and we take for granted.
Yeah, I know that there are other questions, but I'll just echo the importance of your question. And I think it has a lot to do with planning for sustainability. In my prior life, I worked on global health programs on the infectious disease side. And I can think of two specific instances. One where I was trying to get a refrigerator to maintain cold chain in a remote area of Afghanistan, and how challenging that was, because it wasn't just about procuring the device, but making sure it stayed plugged in. But also the notion that, we've invested in laboratory capacity outside of the US, and we have learned from the lesson of not planning for sustainability about the electricity bills, literally, to keep that infrastructure running. And so I think your perspective is critical and needs to be invited early into the conversation for how we plan for infrastructure going forward.
Yeah, I'm unfortunately going to have to stop the conversation there, although we are going to lunch. So I would encourage people, if you do have questions, to mingle with the panel. But just to sort of wrap up, I want to sort of, I guess, underscore some of the themes that have come out, which is, again, to the point about engaging with innovators or entrepreneurs early. I think, Nafisa, you mentioned this, right? There is no one size fits all. And so I think coming together in these forums and having these conversations, and maybe there isn't a sort of a one solution or even sort of a tapestry that we weave together, but at least we're sort of aware of sort of like what Sam mentioned, like what are the things that sort of innovators are really struggling with and can't scale, or what sort of are those needs. And so I want to, I guess, thank the panel for their openness and for being here and being a part of sharing some of these stories. And hopefully, again, these panel discussions aren't meant to be be all end alls. They can't in 1 hour or in one day, but hopefully our conversation starters for either new relationships to emerge or in the networking sessions and reception later on today. So with that, I want to thank each of the panel for being here.